ask a question, feel free to unmute yourself. If you are on Zoom, you can click on the microphone icon next to your name in the participant list or on the bottom left-hand corner of the screen to mute and unmute your audio. For those just using your phone line, again, it's the star key and the number 6, so star 6 to mute and unmute. So again, that's star 6 to mute and unmute. And then if you are logged into the Zoom, you are welcome to type in your questions using the chat feature at the bottom of the screen. So I'm going to go ahead and turn it over to Todd, but I did notice, Tina, you're on the call as well.
Yes, I am.
If that was really helpful last meeting, if you see questions in chat that you can address, just go ahead and answer those. I thought that was great that you were able to do that. So
sounds good. Thanks.
Okay, thanks, Tina. I'll go ahead and turn it over to you now, Todd.
Okay, well, thanks everyone. We're going to kind of continue on from where we left off last time with the blanket waivers. Focus mostly on this one. What I was going to do is kind of go through, if I can here, let me see if I can advance my slides. There we go. So again, here's our Certification Bureau team commitments. Our 5 commitments as a team that we do with our survey process, with any work we do within the department. I'm not going to keep going over these in great detail at this time, just so we have enough time for this entire presentation. So the agenda, we're going to answer. There was one question that came up, I think, that we had last time I was going to answer, go over the blanket waivers. This new QSO 20-30 nursing home reopening recommendations from CMS, and then Tina had a little bit more to address on some of the infection control surveys we've been doing. So she'll answer some of those, and then if you have any other additional questions we can answer, we'll certainly try to do that. So question from last time, one of those was checking of staff frequency, and I think I brought up that when we were up at one of the facilities that they checked us when we came back, even after going outside for a break or going out for lunch or whatnot. And so folks raised the question, is that appropriate or is it not? Is it, should they be tested every time they come in and go out of the, or come back into the facility from even going on a break or a smoke break or a lunch or whatever? And so CMS actually provided, or CDC has some guidance that came from QSO 20-14, and again they updated this for CDC, came out May 19th, 2020. So again, these are, as you all know, these things are changing on a daily basis, and guidance is coming out as we speak. It's difficult to always keep up with it, but it does mention in there about it talks about frequently asked questions in there as well. In this guidance that CMS about reopening, it's tied with that reopening direction that CMS has. But it also comes from that 20-14 memo. They direct you to this CDC document. It gives you guidance on interim. It's called Interim Use Guidance for Risk Assessment and Work Restrictions for Healthcare Personnel with Potential Exposure to COVID. So it focuses on those that have a potential for it. And it does talk about if there has been, so a healthcare professional, HCP they call it in here, other than those with exposure risk described above, which that would be somebody who was directly exposed to COVID-19. There are no work restrictions. Again, it kind of states in here, they tell you, using infection prevention and control practices, include wearing a face mask, which I think most of the facilities are doing, if not all, and not reporting to, not going to work when they're ill, and undergoing active screening for fever or symptoms consistent with COVID-19 at the beginning of their shift. So in my mind, that gives you the ability to just screen them when they come on work, on for their first part of their shift, when they show up for their shift. So the other part of it, though, it does talk about active screening. If, you know, as a person, if they start feeling feverish, if they start having other symptoms during their shift, they should probably be talking with whomever, their infection control person or the nurse or whoever in the facility who's identified, administrator, to let them know, hey, I'm not feeling well, and they need to be evaluated at that point. So the best I can say is that it does really kind of to lead you to believe that it's just required at the beginning of the shift is when they have to be assessed. So the other thing I wanted to remind you all of is that surveyors should not enter if they have a fever either. CMS has kind of spelled that out as well in QSO 20-14. In some of our infection control surveys that we've done, the targeted ones, the surveyors weren't reviewed as they came on site. So, and I know it's kind of an uncomfortable position because normally you can't say, oh, you can't come in our facility because that's part of the agreement that you have with CMS is that you will allow us in the facility at any time. So here is one example where you can tell us, no, surveyor so-and-so with the fever cannot come in. So please screen our surveyors as well. We certainly are screening them as well to make sure that they're not exposed anywhere. We've had some that have traveled out of state, and if they have, we've quarantined them for 14 days before they could ever go back out into the out into the field, I should say, and even from our own offices. So, so again, I guess my main point is here, it really says staff at the beginning of shift is when they have to be tested, not when they go to lunch, not when they go for a smoke break. But I'd give you a caution as to if they start developing symptoms and things, then you want to start looking at them as well. So I believe that answers the question that everyone brought up, and it's certainly all over, spattered all over through all the guidance and the documents that CMS has put together. So I'm going to go on to the next item, which is our blanket waivers. And they have updated it since we last met last week, which is, again, challenging, I'm sure, for you as well as us to try to keep everything in front of us and try to keep it all or at least in our minds to think about as we go through this process. So the latest edition is there, 5/15/2020. I've given you the best, easiest way I've found to find it. It's not as easy as you would think to find. It does have on the bottom right-hand corner a date, so it's easy to identify which edition you're looking at, which is nice, finally. Initially, they didn't do that. They didn't have a date on it, so it was hard to tell if they had revised things or whatnot, but now they're dating them. So these blanket waivers, some of the fundamentals for this is they go back to March 1st, 2020. So they apply any of these waivers back to that date. They do remain in place until the public health emergency is ended. And to me, this would be on a national level, not just a state level. So it would go back until the president or somebody within the federal government says that the public health emergency is clear or is ended. So whenever that date is. CMS does not require to be notified to use a blanket waiver. These blanket waivers are there for you to use it as you need to. And then state approval is required on at some times. And the specifics I can bring up about that is if you're going to use a temporary facility, one of the things that they want us to make sure is that it's safe. There's, the safety and comfort for patient and staff is there. So you can't just use any, temporary facility. You do have to have some minimal requirements met. And then the last thing I would warn you about is watch the wording in these blanket waivers, because to me, at times it's dealing directly when you're dealing with COVID-19 in your facility or with residents coming to the facility that have COVID-19, and then they start kicking in. It's certainly a challenge to try to figure out when they apply. And as I go through these, I'll kind of let you know which ones I think are challenging to do that with. So as we go to the 3-day, the first blanket waiver that comes in, and this is on page 13 of this document. It starts for long-term care facilities and skilled nursing facilities and or nursing facilities. So this is where we're at in the long-term care area, excuse me. There's a variety of other providers in here. There's some other things on telehealth. You just kind of have to look at the titles and make sure you're in the right section and how you would apply it to your facility type. So for this 3-day prior hospitalization, and it's pretty specific, in my mind, it talks about, it's for those people who experience dislocation or otherwise are affected by the COVID-19. So you'd have to, in my mind, demonstrate where it's being, an impact is being felt by the COVID-19 public health emergency to use this 3-day prior hospitalization waiver. So you may not have it in your facility, but you're suddenly getting a lot of admits from a local hospital that's going through the COVID challenges and trying to isolate people and trying to send maybe folks that are not COVID positive to your facility to kind of, again, isolate them from those that are positive and to free up beds and open up beds and things like that. So you've got to consider that when you're looking at this particular one. It does give some specifics on recently exhausted. There's SNF benefits. It authorizes renewed SNF coverage without first having to start a new benefit period. So there's some specifics in here that you want to look at and study up on. It also has some at times it has a Code of Federal Regulation reference that may help you get through it as well. If you have questions as you go through it, let us know. We'll certainly give you an answer of what we know and what we can provide, and even take it up to CMS if need be to get an answer for you. It's my emphasis on this one is delayed or prevented by emergency itself. So it's got to have some impact as a result of the COVID-19, not just because you need to use you need to skip the 3-day prior hospitalization because it's just simpler to get a person admitted to the facility. So you've got to be cautious with these. So then going on to the next one, it talks about reporting a minimum data set. And this one, I think I even produced an email, and I think Marcy has sent it out, excuse me, and it dealt with when you could skip some of the reporting minimum data set requirements. And it talks about, I think in here, yes it does, it talks about the assessments and the transmission of those. So I highlighted the areas that it talks about calendar days and what, those particular time frame requirements that they're exempting here, and it mentions those. Again, I believe this is as a result of if you're dealing with COVID and you're in that mad rush to try to manage that situation where you can, these days are not going to be as applicable in a time when you're normally just admitting and sending your MDS information off. So this is just giving you a time frame to allow for that if you're in a COVID crisis and being challenged by that. So I've just highlighted the areas. There's a lot of wording here. I'm not going to read it all to you, but it gives you the key days that when things are due, and then it tells you timelines. And again, this is a repeated portion of it, or the second portion of it. Again, identifying times, dates, when it has to be submitted. And so I would encourage you to follow this until you get to a COVID situation, or follow the normal requirements. And then if you get into a COVID, then you've got these situations where you can use the blanket waiver and defend yourself if you didn't get it done in 7 days, 14 days, whatever. So that's the reporting of the minimum data set. The other one was the staff data submission. And this, again, it kind of just opens it up to relief long-term care facilities on the requirements for submitting staffing data through the payroll-based journal system. So again, allowing you to have some leeway in this time if you're dealing with COVID and whatnot and being challenged by that. And then going on to waiver pre-admission screening and annual resident review, the PASSAR. This again allows you for level 1 and 2 to do certain things, change some time frames, so they give you a little more leeway on submitting these things. Again, they don't specifically mention it as being COVID specific, but I would caution you to think about that before you kind of push these envelopes if you're not having COVID in your facility. Then it goes on next to physical environment, and here's where it talks about allowing you to use like a temporary location. It does mention in here a state approved, and what does that mean? It's temporary certified for isolation purposes, so if you're going to try to isolate folks that are COVID positive, say it's in a, we'll say a gymnasium in the community or something, community center or whatnot. And so there are some minimums for the state to review and make sure it's safe and comfortable for the patients and staff as well. It also talks about in this temporary COVID-19 isolation and treatment locations. You know, it does, what they're trying to do is free up inpatient care beds at hospitals for the most acute patients while providing beds for those still in need of care. So again, they're trying to, if you've got an active COVID situation in your community, in your county, in the hospital that's in the local community, then this helps with some of that as well. Thankfully, we've been pretty blessed with not having so much challenge of COVID rampant throughout the different counties in our state and throughout our entire state. It's been pretty good overall. And then the next one is, it also allows rooms to be temporarily be used, to be used in the long-term care facility that are not normally considered a residence room. For example, it gives you some ideas such as activity rooms, meeting conference rooms, dining rooms, or other rooms, as long as residents can be kept safe, comfortable, and other applicable requirements for participation are met. So this is, again, this is in result of the COVID-19, and if you've, and hopefully none of you have to face this, to try to use some of these other areas of your facility that may work as a temporary area to assemble or to isolate folks, to prohibit that spread as much as we can. So then it goes on to about 4 other items here. It talks about resident groups, that the CMS is waiving the requirements, which requires residents can participate in person in resident groups. This waiver would only permit the facility to restrict in-person meetings during the national emergency. Again, if and at some point the president or some other federal official will make a call to say, hey, this is no longer a national emergency, and then again these waivers go away. But it gives recommendations of social distancing and limiting gatherings of not more than 10 people. And refraining from in-person gatherings will help prevent the spread of COVID-19. So again, it's kind of letting you it's not a mandatory thing that these resident groups have to meet. Training and certifications of nurses' aides. The next one here, it talks about giving you a 4-month, it used to be where after an aide was started in a facility and in a nurse aide training program, that after 4 months they had to have either taken and passed the exams or moved on and could no longer be at the facility. Well, again, this lifted that 4 months unless you know, it lifts that 4-month requirement, so it would let people continue as they are. They do have to focus on the areas that they're educated in and trained in and show competency in. So I'd encourage you to consider that as well. We would certainly review that during this time as well, as that, you know, person wasn't being such as a feeding assistant at this time and had no training or background in it, or was doing catheter care or catheter services or whatnot and had no background in it or whatnot. So keep that in mind as you go through this as well. The next item was the physician visits in skilled nursing and nursing facilities. CMS is waiving this requirement for physicians and non-physician practitioners to perform in-person visits for nursing home residents and allow visits to be conducted as appropriate via telehealth. So telehealth and telemedicine has been opened up quite a bit because of just the exposure for even the physicians and other healthcare folks. If we can limit their exposure to it, that's better for everyone. The fourth one here is resident roommates and groupings. It's solely for the purpose of grouping or cohorting residents with respiratory illness, symptoms, and or residents with confirmed diagnosis of COVID-19 and separating them from residents who are asymptomatic or tested negative for COVID-19. So it's allowing you to use resident rooms and grouping them in different areas if there's concern and if folks have a positive COVID test. This action waives the facility's requirement and it gives you the regulation to provide for a resident to share a room with his or her roommate of choice in certain circumstances. So again, it's taking some of those requirements out that you know, requesting that you be allowed to pick your roommate or even consider you know, the resident's rights of refusal to transfer to another room, etc. So again, because of the COVID-19, this particular issue would become prevalent, or you'd want to pay attention to. The next one is resident transfers and discharges. And really, I started to go through all this in great detail, but the fundamental thing to keep in mind here with these transfers, and I've got transfers here twice, I apologize for that. Resident transfer and discharge residents to another long-term care facility solely for cohorting purposes. And again, cohorting is the medical dictionary gives an imposed grouping of people such as healthcare workers potentially exposed to designated diseases. So why they've given waivers for these transfers is to give you the latitude and opportunity, if you do have COVID, to work with other facilities in your community, to consolidate those folks that are positive, separate them from those that are not, and for those that are even with respiratory infections, to make that so you guys can work with them together as a group and kind of consolidate and make sure they're all together and, you know, not exposing others within the facility that aren't positive at that point. So it goes through the different transferring those with respiratory infections and confirmed COVID to another facility. There's 3 different options here, I guess. Transfer of residents without symptoms of a respiratory infection or confirmed COVID to another facility. So again, you could work with a neighboring facility to kind of consolidate those folks that are not versus those that are. And then transferring residents without symptoms to another facility that agrees to accept each specific resident for any signs, that agrees to accept each specific resident for any signs or symptoms of a respiratory infection over 14 days. So again, these are just allowing you to kind of manage of that infection as it comes in to your facility on a quicker basis without, you know, having to do the transfers and discharge and all those requirements specifically. The other thing I wanted to mention here is there are some exceptions to it. They do say they have to have an agreement with an accepting facility, so you have to have and I think they even allow verbal on this one, but within a certain time you have to have a written agreement as well. They do talk about advanced notification of options not required, so you don't have to let the residents know that you can go here or you can go there. You're doing this in the case of a public health emergency, so you're doing the best you can to protect these folks from that infection. Written notice can be provided as soon as practicable, so as soon as you can do that, you can give that written notice. It's not required before you transfer folks. Again, this is going to involve COVID-19, so if you have cases of that coming up or just identified, then you got to start dealing with how you're transferring folks. Only certain care plan requirements are waived. There are some specifics that you want to make sure you follow in the care plans. And then it must follow state's emergency preparedness plan. And that's one thing I would like to reiterate here, is that there is, as we all know, we have a governor of this state that has guidance out there too for us all and requirements. It looks like we're going into phase 2 of the reopening plan. One of the things that was pointed out to me is even in this phase 2, they do say that vulnerable Montanans should still continue to stay home when possible during phase 2. And then it states visitation at nursing home and assisted living facilities remains suspended except for certain compassionate care situations. So again, our governor is telling us that, only, and CMS reiterates that in their own guidance that they've given us about, compassionate care or end-of-life situations where visitation should be allowed. So let's go on to the next one, which is physician services. This gets into a little more detail about the physician services and what is waived. The first one, for example, is delegation of tasks in SNFs, skilled nursing facilities. The regulations specify that a physician must perform it personally, so they're letting them delegate things out. We are temporarily modifying the regulation to specify that any task delegated under this waiver must continue to be under the supervision of a physician, so it still must be supervised, but it can be done by others. And it depends on the licensing requirements of the state for the professions that are working under that physician, such as a nurse practitioner, a physician's assistant, or a clinical nurse specialist in the state. So you want to make sure you're complying with those as well. As far as physician visits, it talks about these are the ones that they must be made by the physician personally. And then it brings in the nurse practitioner, the physician assistant or clinical nurse specialist who is an employee of the facility and is collaborating with the physician and who is licensed by the state and performs the state scope of practice laws. So it's given, again, latitude for those physicians, ability to have others help and get them through their workload, and also at times I would assume some of them have been exposed to COVID or may have been and want to isolate themselves and not come into your facility, and I'm sure you don't want them in there either. So physician visits are pretty specifically addressed there. Excuse me. And then the note that they did put on here is that it's not waiving the frequency of visits. These are just how they're done, but not the frequency of them. So how they're accomplished by whom and when is more important than by who is doing it. So as long as you can follow either one of those three other professions to do that, that will comply. Not waiving required physician supervision. So again, they're saying they still have to be supervised by a physician, and oversight must be done. So those are for the physician services. Going on, it talks a little bit more about 5 other items that I wanted to go over. They're not really detailed as what they mean by them all, but one of the things that obviously is QAPI, the Quality Assurance and Performance Improvement Program. They're modifying the requirement to develop really why they're allowing for some changes to this, to the QAPI program, is to allow facilities to focus on care delivery, most closely associated with the COVID-19 during the public health emergency. So, for example, infection control, that's one of the survey aspects that we can do at this point. So we're looking at, you know, the infection control programs for each of the facilities, or for those that we've identified at this point. And as we go further on, if there's issues with infection control, we would, you know, review those as well. So again, they're trying to get you to focus on those areas that are really critical at this point. The next item is in-service training, and it talks about nurse aid training requirements. And it's stating that in the current regulations, it says that each nursing assistant must have at least 12 hours of in-service training annually. Well, they're relieving some of that by saying that they're postponing the deadline for completing this requirement through the COVID-19 public health emergency until the end of the first full quarter after the declaration of the public health emergency has concluded. So again, the president or another federal official has removed that public health emergency. The next item is the detailed information sharing for discharge planning to long-term care facilities. This particular waiver is to provide facilities the ability to expedite discharge and movement of residents among care settings. So again, it's looking at quickly being able to transfer folks in their interest of infection control and COVID-19, being able to do that quickly and not putting a lot of red tape in front of you trying to do that. The next one is clinical records. If somebody asks for a clinical record, typically it would be within 2 days if a resident requested them, 2 working days. Well, now they're extending that to 10 working days. So they're giving you a little bit of reprieve on that to give you some time to respond to some of those requests. Paid feeding assistance, they are addressing this specifically. CMS had a minimum of 8-hour requirement for this in the past. They have modified it to allow the training can be a minimum of 1 hour in length during this, again, during the COVID public health emergency. So those are the blanket waivers that are specific to long-term care. As I mentioned, many of them, there are others for like home health agencies, critical access hospitals. These are specific to nursing homes. So if you have other questions related to another area, you can certainly let us know. The major changes from the last one of these blanket waiver documents issued is they issued some guidance for ambulance services in here, and they also issued something up front here for the major changes on the physical environment for, I believe it's hospital, critical access, and long-term care hospitals. So those are the major changes that occurred in this edition. Nothing really so much for long-term care. So going on, okay, let me through this. Oh, let me go forward. All right, it's locked up on me. Bear with me here just a sec. Come on. Don't go beyond that. Okay, well, I'm going to continue on anyway at this point.
Todd, do you want to stop sharing your screen? I can try and share mine if you're stuck.
Sure, yeah, it looks like it locked up on me here.
Okay. I'm not too sure how many slides you have, but...
I can't There's not
Yeah,
two
Bill is
anymore, I
gonna-
don't see on this. So yeah, the next one was based on life safety code specific blanket waivers. It won't let me unshare here. Let's try it again here. Nope, I can't. I don't know if I can even unshare it here.
Oh, it looks like you're
Presentation.
your- slide on your PowerPoint. You must be unlocked.
Okay. Okay, there we go. Finally.
Okay.
Sorry about that. Okay, so going on to the physical environment, they did gave some blanket waivers to give you some necessary adjustments for schedules, inspections, testing, and maintenance for facility and medical equipment. But it does list some things it doesn't include, such as a sprinkler system, monthly electrical motor, and weekly diesel engine driven fire pump testing. So fire pump testing that's either of those type, either electrical, diesel driven. It talks about the portable fire extinguishers still have their monthly inspections. And then there's some specifics on elevator, firefighter, emergency operations, a monthly test for that. Emergency generators, the 30-minute continuous testing, monthly testing, and then associated transfer switch testing as well to make sure that's all functioning. And then maintaining the means of egress daily in areas that have undergone construction, repair, alterations, or additions to ensure its ability to be used in instant case of emergency. So again, making and maintaining those means of egress, as you all know, are pretty important. So, and then the other thing it does waive is though the outside window or outside door. There is a requirement in the code that CMS has, and it's really not in the code. It's actually something they have adopted. Is that every resident room must have either an outside window or an outside door. Again, if you're in, say, a activity room that has no window or whatnot, this would let you use that room based on this, this environment, physical environment waiver. So, again, this is dealing with addressing the life safety code and the adoption of that and what things they must absolutely have to be done during that time, even in the COVID crisis. So then going on to more specifics that they've brought up beyond that for, I think, not only long-term care but other facilities is the alcohol-based hand rub dispensers and how much or those are in the smoke compartment and things like that. It does, because of this, the need for hand hygiene and things like that with the COVID, it does talk about some exceptions, access by certain patients. So you still got to consider, are certain patients going to maybe harm themselves with the ABHR materials, to prevent ingestion, whether it's kids, maybe mental health patients, whatnot, vulnerable people. The other thing it talks about is ethyl alcohol. If that's used, to limit it to less than 5 gallons per smoke compartment again. And if it's over 5 gallons, then it has to be stored in a hazardous materials area. So you don't want to have a huge container of it or whatnot. It has to be less than that 5 gallons and no more than that much in that particular smoke compartment. It does also address fire drills, and it talks about documenting the orientation training program rather than going through the process and running a full fire drill where you pull the alarm or you have staff move around the facility. again, in the interest of not putting people at risk for COVID and whatnot, they've kind of lowered that requirement. The other thing is temporary construction. If you needed it, and I've had a number of facilities, or we have had a number of facilities talk to us about, you know, temporary isolating a section of a wing of say the wing of one side of the building, maybe the last 10 rooms or something, and using temporary barriers to do that. And certainly they're going to allow you to do that here, you know, if needed, to isolate or to even quarantine people or whatnot. So those are the other things that you want to consider or be aware of. They're actually listed in here, and I can't remember which page. I think it's page 25 on here. It starts going through those and the specific physical environment waiver information. So, and it runs through, I think, into 27. So you want to look at those and see if they apply to your facility, see if you can use them if you need to, but they are there as well. So I know there's probably a lot of questions. As I said, this is difficult for us to keep up with. I can only imagine for you, trying to operate your facility and trying to understand all these changes. I think the one thing you got to keep in mind is these waivers are just really associated with COVID-19 if you're having challenges with that. And it doesn't mean necessarily you have it in your facility, but if you're receiving additional residents and that from a local hospital, or they're being directed to you to receive and try to isolate and deal with them as they come in, that certainly would apply some of these waivers as well to you. Certainly if you have positive COVID-19 in your facility, that's going to create much more challenge and work on your behalf trying to manage that. So is there anything specific, any questions that I can address, or do you want me to just keep going on?
Todd, I don't see any specific questions on waivers. I just did want to go back to, there was a comment from Elizabeth Adams, who was a surveyor, when we were talking about testing or screening the surveyors when they come into the facility, and she just wanted to mention that on the survey she did this week and last, that she had brought in her own lunch and did not leave the building for a lunch break. Her lunch was in a washable bag that was wiped at the entry point. So just wanted to read her comment, and then I think maybe go ahead, let's just go ahead and have you continue on through your presentation, and then we'll go back and go through the questions if we have time.
Okay. All right. Again, I just wanted to update you on these civil monetary penalty dollars that are available. We've had 28 facilities apply and be awarded for this communicative technology request, so these are with the iPhones, iPads, whatever. So there's a large group of folks that have applied for it, and I encourage, we have 71 total facilities. I'd encourage you all to do it. I think it's pretty straightforward, nothing too complex, but it allows you to get some of these devices maybe that would help you deal with folks in communication with loved ones outside the facility for residents. So the other thing I think that we kind of came to realize, there's another group, and Darcy, Marcy, you may be able to address this better than I, but there was another Department of Commerce had some kind of a grant as well that was for communication devices, and maybe you've already shared that, but
right, and we did send that information out. I believe it came from Mary Erickson on the listserv, who's our program director. Just I can resend that out to folks just to take a look at it, to take advantage of all these programs.
The other thing I wanted to mention is CMP funding, the normal requests that we have, and there's over $4 million in CMP monies that you could have access to. That is the next due deadline for those larger ones is September 30th, and there is a website. It's through Senior Long-Term Care Division. We do get involved with review of them just from the standpoint of understanding you know, whether they're qualified as a long-term care facility and reviewing all that part of it. But Senior Long-Term Care Division of Department of Public Health is the one that ultimately recommends to CMS, and then CMS has final approval, but those are due by September 30th of 2020. So they collect those twice a year. Last one was March 31st, and the next one will be September 30th. So I'd encourage you to apply for that as well. Tina, are you still on with us?
Yes, I am.
I've got the targeted infection control surveys trends up. I don't know if you have anything you want to add for those.
No, really for those, the ones that we're most currently doing, I don't have any of the results for the ones that have been done over the last week. And I'm wondering if the question that we have in the chat about the hand sanitizer has to do with that, because that doesn't sound familiar. But is what we're mostly finding is that the facilities staff aren't necessarily using their PPE appropriately, or they're not screening appropriately when staff, family, or visitors are coming into the facilities. Really, most facilities are just doing really well overall, but those basic infection control practices seem to be the ones that are now starting to cause issues for the facility, from the sounds of what I was told this week. But again, I didn't see the reports yet for this week. So other than what we have currently going on, really the PPE, the screening, and making sure that your staff and residents are trying to distance as much as possible, and then also communal dining. We have quite a few facilities that we're still continuing to do communal dining and communal activities with large groups of people.
So Tina, in response to that question that's in the chat where they were cited for not having the hand sanitizer on the dining tables, however, they have a high dementia population and it's dangerous to have them out, just wondering what is the right thing to do. Do you have any further guidance on that, or again, is that something you need to look at specifically on a survey?
To be comfortable, I would really like to see the survey and the evidence that the surveyor gathered to see what comments were made from staff, if they interviewed staff, specifically, or if they interviewed the DON, anything like that. But obviously having sanitizer out with residents who have dementia would be a concern for safety. And so I would automatically be looking to see how the facility is mitigating concerns and ensuring safety. So, but without really seeing the report, it's really hard to speak to.
Okay, thank you. And there are a few more questions. Todd, remind me, were you going to, I know we're getting close on time and well, we have about 10 more minutes. We're going to just maybe briefly talk about the new guidance that came out and offer any comments and thoughts on that.
Yes, I'm sorry, I forgot about it. QSO 20-30, the new one that came out May 18th. And this really, one of the things that I really pay attention to closely on this is its recommendations for state and local officials. So it's really not mandatory or thou shall from CMS standpoint, but it is good guidance. Again, I would point out that where our governor is as far as, providing us, we're at, which one are we on? Phase 2 of the reopening plan. Anyhow, he's still, again, he says visitation at nursing home and assisted living facilities remain suspended except for certain compassionate care situations. So with that being said, this particular document, we've not had a whole lot of time to work through or consider where it's going from here. The one thing, I guess, for me, and you all can say or chime in where you think it's appropriate, but the testing portion of this seems more robust than, at any time at this point to allow you to freely open up your facility. as we go down through these phases or through this guidance. So, you know, again, it seems like testing is going to be pretty critical, and I don't know, personally, I don't know availability of testing for all facilities to even use at this time or to access. So, with that being said, we're going to have to review it and go through it. It is just recommendations at this point, and we'll have to see where we head from here, and align with what the governor is going to say, you know, for the state as well, at the next phase. So.
And Todd, I know that we had discussed this morning that, you know, of course, there's going to be lots of questions. So maybe after you all have had time to get through that, and maybe we can have, you know, another call to go over questions for folks and any information you'd like to share. Okay.
Yeah,
let me just head back up to the, I'm sorry, Todd, were you finished then? Can we start going through a couple questions here before we?
The only thing I would suggest, there is another, there is one other thing that CMS referenced. It's called nursing home reopening recommendations and frequently asked questions. And so sometimes it may help you through this process a little bit, explains what CMS is thinking at least, and gives you an idea. So I'd suggest you look at that too, and I can certainly send that on to you too, Marcy, to email out.
And we did, when we sent out the guidance, or when I sent that out, I did also include that FAQ. So
oh, good. Okay. Thank you.
That went out. But those are pretty helpful. Okay. Do you want to go ahead and take a few questions then?
Sure.
All right. So the first one we have is that we're a CAH with a long-term care swing bed. Do we follow the same guidance as nursing homes? I assume that we do. However, the statement there's a statement that talks about senior care facilities. And again, this is related to the recommended nursing home phased reopening. And so they don't know if they are termed a senior care facility or a nursing home. The term senior care facility refers to a broader set of facilities that may be utilized by seniors and is not specific to certified long-term care facilities like a nursing home. So whereas this guidance is specific to nursing homes. So she's looking for, so wants to make sure she's looking at the right guidance. I should be looking at the one that is for visitation guidance for senior care facilities. Again, they're a CAH with long-term care swing beds.
Yeah, and I believe, Marcy, maybe you've already sent that question to me. Somebody did. I recognize the question, and I haven't had a chance. I haven't had a chance to review it and go through it, but we will. But it's a good point to point out that, like 20-14, nursing home is specific to just nursing home facilities that are certified as such. CAW with swing bed is a different regulation set and has different regulations they must follow. They do sometimes refer on to, or they'll reference onto the nursing home regulation set, but most of the time it's, you know, specific to CAW. So let us look at it and give you a good response. But for the most part, and even, you know, I guess in the one sense I would like to point out too that CMS, even this QSO 20-30 is really focused on nursing home. It's nursing home reopening recommendations for state and local officials. Whether they'll have one specific for critical access hospitals, we don't know. Hospitals, you know, the other provider types, you know, inpatient hospice is another one that's very similar to long-term care, but it is unique regulation set and they have some different requirements. But at least for now, this one is focused on nursing home. And I think they did that purposefully because of the vulnerable populations in these facilities. So it is a good point, and you got to make sure you're looking at the right regulation set and applying it appropriately. So we will respond to that question and get it back out by the end of the week here.
Okay, That is great. That's very helpful. And then let's see, there was one, hang on. Okay, so this might, if Pam or Erica Rajos are on, this, the question for Todd and Tina on the current Sentinel testing process, so that's why if Erica is on, she might want to chime in, but this again goes to the given direction from the state EPI team that initial positives for asymptomatic from this Sentinel testing process will require confirmation testing be completed. The initial positive test will not be treated as a confirmed positive by the state and local public health until confirmation testing is completed, so we're advised not to complete the CMS mandated notification, communication to residents and families until the confirmation testing is completed. Is that the same understanding the state survey and CERT team has? And I know we visited about this a little bit this morning, so.
Yeah, this is, we are still working internally to kind of make a decision on this. I know Todd also has a question to CMS about this. If you can tell me what facility you're associated with, I'd be happy to give you a call, but we have not made a final decision regarding that. Other than what we did talk about this morning was to treat it like a positive, even if it's just the first test. But I know we are trying to clarify that with CMS, and we'll get kind of official language out there. Todd, did you want to add anything to that?
No, I just say that we did ask that question specifically through CMS, waiting for a response, and as soon as we get that, I will share that with Erica and certainly with Marcy as well.
Okay. And then just another comment from Elizabeth that she had a provider last week ask for residents that had to go out of the building for a doctor appointment. Early on, they were being quarantined for 14 days. And what is the isolation precaution? What isolation precaution should be posted, as none of them had droplet or contact?
Is that a question? I guess that is a question for me, or?
I don't. Is that is Elizabeth? Is she? I'm guessing she's a surveyor.
Yes, she is.
Yes, I'm sorry, can you hear me?
Yes.
Yes, we can.
It was from this week, and it was a provider that had quarantined 3 residents for 14 days. They were still in quarantine while we were there. And they did have signage posted at the room with the PPE available to staff to use for the 14-day quarantine. These were individuals who, had to go out for medical care. And so anyway, the question was, they went right to the doctor's office or right to the hospital and back. And so they were wondering, should their signage be droplet or contact, or what type of signage should they post for those individuals? Because as far as they knew, they weren't exposed to anyone. They had no symptoms, respiratory symptoms. And so it's kind of confusing. And we did look at the CDC recommendations. So I just told them I'd bring it back to our office and ask.
Well, that's a good question, Liz. We'll have to take a look at it and develop a response and get back with them. Because I would assume, again, the only thing I would say is we've had, and Erica is one that kind of brought this forward to us, is that we've had a case where a person came in, kind of a different scenario, but came into a facility, not a long-term care, but assisted living, that was identified positive after they arrived. They had quarantined that person already, which was good, and it protected the assisted living from spreading it throughout. So it's difficult at times to determine when that has to be done. Does it absolutely have to be done every time somebody leaves or not? So let us look at that part of it as well for residents, not just staff.
Perfect. Thank you, Todd. And yeah, it was a special circumstance for each of these residents where they had to be out of the facility to get medical treatment. One of them was for a newly diagnosed cancer patient. And so they did all the right steps with quarantining, putting them in isolation, using precautions, and they had droplet precautions in place. But it did come up as a question that would it just be contact? Would it be droplet if there were no symptoms? And I did review their policies and procedures and their protocol for new admissions. And so that definitely wasn't an issue at this point for all of the COVID CDC requirements for new admission. But for these three individuals, it was just a question.
Yeah, it's a good question.
Okay, yeah, if you can add that to your list, Todd.
Sure.
And then just, I know we're a little bit after 3, but just let me go through just a couple other comments. That QSO 20-30 NH was specifically written to state officials, and the document clearly looks to states to provide guidance. And it feels premature for nursing homes to look at developing protocols unless they, get the state's direction. It would be nice if we could get a sense of timing of release of your determination.
Well,
so,
I'm sorry.
Well, go ahead, Todd.
I was just going to say, yeah, they're absolutely right. And, we've begun discussions here internally within the department to try to get some guidance on it. So I don't know for sure when that'll occur. I'm hoping by next week we'd have some kind of direction and be able to go forward with it. That's what I'll request. In fact, if you want, we'll present again next week, either Wednesday or Thursday, whatever works best, and give you what we know at that time.
Okay, so would that give you guys enough time, another week, to maybe pull some additional info together?
We're going to be upright and truthful about, where we're at with it, though, too, if we're not far completely through it, but we'll answer any other questions, too, at the time we can. As you all know, this is a difficult process, challenging for all of us to learn on our feet here and try to get it, in front of us the best we can, and with things changing every day. So we'll do the best we can.
Okay. Yeah, I think that's good if we just are able to stay in touch with everyone around the state. And then just a comment that, we are rural since we are rural/frontier, we are already seeing a big issue with getting the specimens to the state lab. We do not have a very good courier system set up out where they are in Plentywood. So in the future, worried about timely testing. So very valid.
Yeah, absolutely.
Okay. Let's see. I think so with QSO 20-30, if we already met the criteria in the phases in the last 28 days, can we advance to phase 3 for mental health for our residents?
Again, I would encourage you to look at what the governor's restrictions are as well. It's up to them, as the state government as well, to control that portion of it. I hear what you're saying, and I've had the discussions about being able to have residents even visit from distance, 6 feet away outside the facility. Those have come up as far as for mental health and things, and I certainly understand that part of it, and certainly for myself, appreciate how, that would make me feel as a human being as well. But I would encourage you to look at the state requirements as well before you start going fully open. We will get you the best we can as far as how the state is looking at this, but again, I'd look back at what the governor has issued to us as a state, and again, visitation is one of them he's suspending. except for those compassionate care situations. So it may be a good question for the governor's office and to bring that forward and bring that point out, that some parts of our state did not have as much issue or have as nearly hardly anything of COVID come their way. So is that fair to always have them, you know, be isolated as well at this point? But again, something we'll have to look at and give you a better response.
Okay, and then there was just one comment. We were told if they went to an MD appointment or an ED, you don't need to isolate at all unless symptomatic or known exposure.
Yeah, you know, I guess I wouldn't disagree with that. You still got to monitor every day for residents and make sure there is nothing, you know, changing conditions for them, as well as your staff. So you're going to be continuously monitoring it for some time. It is really, I mentioned this last time, it's managing the liability of what's in front of you, the COVID issue, and, you know, keeping it out of your facility. So.
Okay, and just a comment that, you know, thank you, Todd and Tina, and regarding opening guidance, whatever the department comes up with, let's provide 2 weeks notice before implementing as a state. It should also come off as guidance so the facilities can choose to be more strict.
Sure, absolutely, yeah.
And just, this is the last question, and then we'll sign off, but I want to ask about the CMS guidance about phase 2, that long-term care staff would be testing weekly. Is this something Montana is looking at doing? Again, do you have any thoughts on, I know the testing, again, you mentioned being kind of burdensome.
I did, and that is one of the areas I'm concerned about as well, is where are we at? Can we even do that? That's going to be a challenge for us, let alone you. And I'm thinking about it even for our own surveyors here in our department. I don't want to send them in if they've been exposed somewhere either, so I want to be able to make sure that they're okay and that they don't bring something in as they come in. So something that's very near and dear to me as well is that testing part of it. And, you know, how do we get it, where do we get it, and when do we get it? So yet to be unanswered, but we're working on that.
Okay, well, we will keep plugging along, and thank you again, Todd and Tina. And we will just, I know you're compiling a list of Q&As, and then again, we will just try and reconvene with folks and let you all have some time to, you know, prepare and review the information. I did want to remind folks that every Thursday from 2 to 3 p.m., Erica Arajos and Pam Webb host an infection prevention call. If you haven't joined these, I encourage you to do so. They are very, very helpful and informative. I believe tomorrow's session is kind of an open mic Q&A. So as soon as I get that information from Pam and Erica, I will forward that on. So those are on usually Thursdays at 2. And sorry we ran a little over, just important information, and we will look forward to visiting with everybody again, and we will post this recording when available. I'll let you all know. Thank you, everyone.
Thank you.